Welcome, and thank you for joining us for this Flinders University Meet the Minds lecture that is on a topic that's relevant to all of us, but is sometimes a topic that we shy away from in our society. Today's topic is on the innovations for end of life. We'll be looking at the emerging technology in the palliative care sector. My name's Alan Sicolo. I'm from Flinders University in the Meet the Minds team, and I'm really excited to host today's event as we explore the role of innovative technologies and how they can play a role in palliative care, planning and processes within the aged care sector. To begin with, I'd like to acknowledge that we're hosting this forum on the traditional lands of the Kaurna people, and that we pay our respects to the elders past, present and emerging. We also acknowledge and convey our deep appreciation to the elders of all nations upon which Flinders operates. This event is delivered as part of our Meet the Minds lecture series, lunchtime lecture series, where we give you the opportunity to meet some of Flinders University's most engaging minds as they bring to you some of their latest research from a diverse range of fields. Today, we are very fortunate to be hearing from Dr. Priyanka Vandersman, who is a research associate within the technology innovation stream of the LDAC project. And for those who don't know, LDAC stands for End of Life Direction for Aged Care. Priyanka is part of the College of Nursing and Health Sciences at Flinders University. Aside from being a digital health technology researcher, Priyanka is also a registered nurse. Her work focuses on delivering, implementing and evaluating evidence-based palliative care interventions for the Australian aged care sector. As always, today's event, we love to keep them interactive, and today's event will have live Q&As. That's your chance to participate in the discussion and pose questions to our speakers in real time. I will just remind everybody that we like to keep these sessions, these forums, as a place of respectful engagement, where people are treated with dignity and where differing views are tolerated. We are ready to start receiving some questions, so please use the chat functionality if you'd like. I may hold them off until the end of the session, but without further delay, it's my pleasure today to invite Dr. Priyanka Vandersman to present. Thank you.
Thank you very much, Alan, for that wonderful introduction, and thank you to the Meet the Minds team for the opportunity to present today. So, like Alan said, today I'm going to talk about innovations for end of life. When talking about end of life, innovation for end of life, there are two parts to that phrase. We've got innovation and end of life. Most of us here probably would have a good idea in terms of what innovation means. It's just new and improved ways of doing things. But what does end of life mean? We all know there is a beginning to life, which is birth, and then there is an ending to life, which is death. And we have our beautiful journey of life in between these two. So when are we at end of life? Well, there is no gold standard definition for end of life stage, but if we look at the literature, it tells us that care at the end of life is provided to those who are in the last year of life. And a major component of end of life caring is actually about the focus of letting the person die with dignity. So it's generally understood to be the last 6 to 12 months of our life, end of life phase. But when talking about end of life, I think it's really important to also think about the concept of palliative care. And that's because these two terms are used very interchangeably, but they aren't necessarily the same thing. The World Health Organization notes that palliative care is an approach to care that aims to improve quality of life of people and their patients and their families who are living with incurable illnesses. And if we look at Palliative Care Australia, we can see that palliative care is not just about care that's provided to people in the final stages of life. Sometimes palliative care is really beneficial as an approach to care when provided to people with life-limiting illnesses alongside their active treatment. So if you think of it, palliative care could be like this broader umbrella which encompasses end-of-life care within it. But you may ask, why should we care about end of life? Why care about end of life care? Two key reasons there. The first one is at some point, everyone who's born will die. Life has 100% mortality rate, and the rate of aging and dying is increasing at a rapid pace. We are an aging population. We're living longer and we're getting older. And the changing demographics globally means that health and social systems across all countries need to be prepared to meet the need of these shifting demographics. And a part of meeting that need actually of the aging population specifically is ensuring that the care that they receive during the last year of life all the way through to their death is dignified and in line with their wishes. So let's look at where our older people are receiving end-of-life care. And for this, we actually need to look at where are our older people dying. If we look at the data from the Australian Institute of Health and Welfare, it tells us that 43% of deaths of people over the age of 65 occurs in residential aged care setting. So the residential aged care setting seems to be a major provider of care to older people who are at the final stages of their life. And end-of-life care is increasingly becoming the core business of residential aged care. So we know that cost of high quality care is pretty high, and the resources that are available to us are pretty finite. So we need to think about innovative or clever ways to really facilitate end-of-life care provisioning in the aged care sector. And technology is one of such approaches that really brings that opportunity of innovation into end-of-life caring. So let's look at technology and aged care. What do we know about that? So we know that technology is utilized in aged care in various different forms. We have got consumers and their families using technology. We've got care providers, clinicians using technology in their work capacity, but also as individuals. We've got organizations, systems, and governments even increasingly relying on technology. In terms of looking at the aged care sector and their specific engagements with technology, some of the ones are the ones that you could see up there. So administrative and educational use of technology is really heavy in aged care sector. Things such as finance or payroll, staff education portals are pretty uniform across most of the aged care services. Post-COVID, the use of technology for telehealth has also really picked up. The other way technology is used in aged care is clinical care. So the clinical, what I like to call them as clinical data management systems, platforms or softwares that actually provide services with, a system to collect their client or their residents' healthcare data, assessment forms, records and documentation of care, so all that sort of thing. And these platforms and softwares are mostly provided by commercial IT companies. And then there's this very small proportion of aged care services that actually use some very advanced technologies like, robotic trolleys and, companion robots, virtual reality, sort of mediated care, voice over text, but they are very small minority. And given the integration and use of technology in the aged care sector will likely continue to rise in future, we really need to think about how can we leverage technology to facilitate caring at the end of life, given end of life caring seems to be the core business of residential aged care or aged care overall. So to look at, what's happening in the sector, one of the projects that really looks at technology-mediated ways to enhance quality of care at the end of life is LDAC project. LDAC stands for End of Life Directions for Aged Care. It's a federally funded project, and it's run by a consortium of 3 universities and 5 peak bodies, as you can see there from the logos. Now, the broader aim of the national level LDAC project is to support the aged care sector in providing quality palliative and end-of-life care. The technology and innovation stream within LDAC looks at developing, testing, and implementing various technology solutions that could help aged care providers to plan and deliver quality care for those who are at the end of life. The technology innovation stream has a range of different projects within it, but today I'm going to talk about one of the major pieces of work that we did as part of the technology innovation stream, which was developing, integrating, and implementing the LDAC digital dashboard. So let's have a look at this dashboard. Here you can see a little screenshot of the dashboard prototype. Now those numbers you're seeing there in the pie chart, those are based on a dummy data set that we've got in the background. In real life, those data would be live from the clinical data management system of a service. So the dashboard essentially is a web platform. What it does is it serves as an automated system to capture and interpret important data points that relate to end-of-life caring processes in aged care. So the principle here at work really is that aged care services already collect a huge range of clinical and assessment data. Things such as, does this resident have an advanced care plan? Do we have a substitute decision maker for this resident? Or, have we had conversation about end of life care planning? These these data points are already there and most likely sitting somewhere in the electronic system. So what the dashboard does is it provides a framework for picking up those relevant data points, and then it presents it back to the clinician in a way that is clear and meaningful in the context of end-of-life care provisioning. On the green panel there on the left, you can see various different menu items. So those are the things the dashboard tracks. All of these are very important components of a comprehensive end-of-life care planning and provisioning in the aged care sector. For example, we've got advanced care planning and recognizing end of life, assessing palliative care, and so forth. And these all come from the evidence-based LDAC care model. Moving on, I want to talk about one specific element of the dashboard, which is recognizing end of life. Recognition of end of life is really important because unless we recognize when somebody starts to deteriorate, it's really tricky to understand their needs and cater for that need. So how does the dashboard help clinician and care providers really pick that up? So for the purposes of the dashboard, we've used what we call the SPIC tool, or what is a SPIC tool, it's the Specialist Palliative Care's Indicators tool. It is an evidence-based, reliable and valid tool that really helps clinicians and care providers locate where their resident is in their decline trajectory. Now, for the purposes of the prototype, we picked this tool, but if there is a service or an IT provider that uses a different tool, say a surprise question, or if they have some internal clinical process of assessing and situating where a resident is in the trajectory, the dashboard allows for that flexibility. As far as there is a process to pick that up, the dashboard can work with that. So there's no rigidity there. And similarly, on the right-hand side in the EOL statuses pie chart, you could see that we have, for the purposes of this prototype, classified residents into 3 different categories in their decline trajectory. Now, there isn't a gold standard or a uniformly accepted terminology of classifying people in the late end of life stage. In the end of life stages. So what we have done is we've said, okay, for the purposes of this, we're going to give 3 tags. But if a service or IT provider says, no, we do this, but we do it differently, we use different terms or we use different process, that is fine as well. I'd like to quickly define what we mean by these 3 categories. So not EOL is your residents who are living well with some support. There is no evident or no clear sign of irreversible health decline just yet in that person. Your EOL recognized or end of life recognized are those who are starting to show some form of health decline and deterioration. It's not just frailty, there's something else going in there. You wouldn't be surprised if this person dies in the next 6 to 12 months, that category. And then your EOL dying are the ones who are actively dying, those with symptoms such as rattly breathing and lapsing in and out of consciousness. So you wouldn't be surprised if this person dies in the next few days or weeks. So that's how we have classified. But like I said, there is no need for the terms to be rigid. The dashboard offers that flexibility. So in the next slide, I want to talk about some strengths of the dashboard. The first one is its adaptability. So like I said, the dashboard works with tools and processes and mechanisms that are already at place. So it's not going to conflict with workflows of a service or of a system. Also, the other very strong point about this dashboard is it integrates into existing clinical data management system. If you look at the aged care IT sector, it's so fragmented. You've got standalone softwares for almost everything. You've got a different system for food ordering, different system for payroll, different for finance, different for rostering, different for ACFI, different for clinical data management, like you name it. They're just everything is, they don't talk to each other and they're all very standalone and unique. So when we started this exercise, we said, no, we will work with what's already there. The strength of the sector is that it does collect data and most of it is electronic anyway. So the seamless integration into existing system, I think, is a really big plus. The other thing is the dashboard is a very rigorously built product. It's based on relevant aged care policies and guidelines and end-of-life care evidence. The other thing is that in terms of clinician and care providers using it, there is no need for duplicate data entry. I think which is a really big thing in a busy and a complex setting like aged care sector. So when somebody collects the data about Mrs. Jones has had her advanced care directive done today and enters that in one place, say in their clinical data management system, there is no need to feed that again to the dashboard. It picks that up already, which is a really great plus. And real-time updates. That's another thing in that, there is no need to wait for 6 or 3 months to see how you're going or how your service is going. The updates are instant. And if you think about aged care sector that gets, random accreditation visits or, board meetings to discuss some crisis, it's really good to be able to just look at the dashboard and be like, how are we doing up until now, instead of having to rely on reports that would be generated in future. So that's a bit about the information on the prototype or the dashboard itself. Now, the prototype was finalized late 2019, and we've done some work after the prototype was built. So early 2020, we opened it up to the aged care IT industry and invited them to submit their interest. We called for an EOI for IT companies to, sort of get in touch with us and tell us if they would like to integrate the dashboard. And we had 8 companies who submitted their EOI, and 4 embedded the dashboard within their system. And out of these 4, 2 companies were actually able to provide the dashboard access instantly to their aged care clients. So the availability of the dashboard for use in the aged care sector really led us to the next stage of our work, which was doing an implementation evaluation study. We really wanted to see how the dashboard would perform in the real world aged care setting. So we set out to do an implementation evaluation study. So between June and December of 2020, we conducted this study, and we ran the study across 14 different residential aged care sites. In terms of how the study ran, we had a dashboard champion at each site to support the initiation and continued use of the dashboard by the site staff. As a research team or a research of the project team, we provided staff training on how to use the dashboard, after which each site was asked to use the dashboard for up to 8 weeks. And then what we did in terms of data collection was we collected focus group and interview based data at the beginning of the 8-week dashboard use period and at the end of the dashboard use period. So that was the study design. So what did we find out? Before I even begin to talk about what we found out, I want to say that we had 72 staff consented for all the data collection points, and 57 of them took part in the focus group or interview. Now, for those who are familiar with the aged care sector, though, they would know that for a 6-month study with a complete engagement of 3 months, that number is huge. We had 57 staff in the middle of Royal Commission. COVID was rampant and aged care sector is busy as it is. We felt that the desire to engage in being part of this exercise to test technology for end-of-life care was really big, which was very nice and very promising. So in terms of what we have found out from from our chats, our focus group, our interviews with the care providers and clinicians is 2 key things. The first one was that the dashboard has the potential to enhance workflow. So what the staff were telling us was that there was this disconnect previously before the dashboard. There was this disconnect between the fact that data exists somewhere there, paper, maybe in some corner of the clinical data management system, and the ability to actually access that data in a timely and meaningful way. What the dashboard did was it acted as a bridge. If the data was there in relation to things that are important to end-of-life caring, like does advanced care plan exist? Does this resident have substitute decision maker? If the data existed, it was very easy to really look at that data. So that that bridging that disconnect was really big. The other key thing that we found out was that dashboard improved resident level outcomes. So the ability of the dashboard to prompt aged care workers to identify, missed opportunities, missed care activity, or missed documentation, really acted as a prompt for them to carry out communication with the family or initiate a process of something that related to end-of-life care planning. And what that did was that really ensured that the care provided to those who are in the end-of-life stage was well planned. Families were involved more in conversation of decline and deterioration early on in the pace, and ultimately the care provided was in line with what the resident and the family had wished for. So those were the values. The other things that we learned were some considerations, which was, some technical challenges were encountered in integrating the dashboard into the IT systems. But again, those weren't anything unusual or unexpected. Given the dashboard was integrating directly into a database of, health and clinical data, there would be some consideration around, safety or data conflicts that need to be, thought through. And that would have been the case for any kind of integration of any kind of software that really exposes the, a database full of health and care information. So that just came out to be like, oh, this is, this happened, but this is nothing unusual or unexpected. And the other thing was the need for support to users post-integration for IT companies that integrate this sort of new mechanism or new dashboard. It's not enough to just do a successful integration. There was some desire from the end users, the aged care services and the staff, to be able to go back to the IT company if they had any question. So those are our findings, but what did we actually learn from this whole exercise? Well, firstly, the fact that we were able to do the study and see value, or value of the dashboard in real life, really made us feel that, well, it really is feasible to work collaboratively with the sector, and it's really, and they're really open to testing out and working towards meeting the end of life and palliative care needs of their clients and residents. So that was very clear. The other thing was that it's not sufficient to just develop products. Products need to be designed and developed with intended users, and they really need to be tested in situ to really find out, what's happening, what's working, what's not working, what's the value. So we can't just build and forget. So that's what we learned from our implementation study. So what are the next steps for dashboard? Where to from here for the dashboard? There are a few things that we're doing in the background. The first one is that we've got some activities in place to promote wider integration of the dashboard across the aged care sector. The other thing we're doing is we're trying to see if we can extend the dashboard into home care sector, because the sites that were involved in our implementation study really were all residential aged care sites. So we're really keen to also, see the applicability and feasibility of using this dashboard in the home care sector. And we're broadly doing some marketing and promotions work to raise awareness about the dashboard in the sector, which will be, going on from now up until end of this year. So that's where the dashboard will be heading. But I think we need to go beyond that. We really need to go beyond that and ask ourselves the question of where to from here for technology in aged care, and where to from here for technology in end-of-life caring. Is technology the idea whose time has come in the aged care sector and for end-of-life caring? And to some extent, I think so. I really, really think so. Because if we look at the Royal Commission's recommendation around the need for appropriate technology implementation, and then at the same time, we've got the aged care reform agenda's push for technology use in the sector. I think that provides an ideal opportunity to expedite the work of embedding technologies to facilitate end-of-life caring in aged care. And we can see that, agencies such as the Australian Digital Health Agency, the Aged Care Industry Information and Technology Council, and commercial IT companies have really welcomed this opportunity. And for a project and a research group like us, LDAC, I think this is an exciting time. It really brings the prospect of working collaboratively with the sector, with policymakers and end users to build, test and deliver products that could improve the quality of care that's received by older Australians in the last stages of their life. And I think that's really, really meaningful. And I think that brings me to the end of the session. Thank you very much.
Wonderful. Thank you very much, Priyanka. We are starting to get a few questions from the audience now, please, but I'd like to encourage more if anyone would like to ask a question. The first one is, can you provide any advice on how to help staff at residential aged care to use this sort of technology effectively and maintain the dignity of older people?
Yes, sure. So given this is a technological product, and putting in any sort of new change or anything in a busy setting like aged care is always going to be very tricky. I think the real value of the dashboard, I think, really needs to be communicated. That's really key. One of the learnings for us from the implementation study really was, to tell the care, because they care about the residents. It's really important to say, why does this matter? How is it going to make your life easy, and how is it going to impact on the outcomes of your residents and clients? But also, I think there is this huge piece of having the service level interest in integrating and having the dashboard used as a mainstream as well, because without that organizational support and a bit of a structure to use the dashboard, it's almost impossible for an individual clinician to just go solo in terms of using this.
And how can aged care organisations actually get access to this technology? Who's it available to?
Yep. So as part of our LDAC project, sort of output, this prototype is really open for, use for the sector. But the way this works is the integration work has to be carried out at the clinical data management system level. So I wish it was a plug and play at a service level. That would have been really, really easy. But given the complexity of how the dashboard runs with existing data that's already collected, IT companies that are servicing aged care services, so, essentially your providers that keep the data of care and health and all of that, they need to work with us to integrate the prototype within the system. And then the next stage would be looking at supporting the organizations to implement it at the site level. So it's a two-step process, but the complexity of this work requires a IT company level integration. But then, I say that was what we thought, but then when we did the implementation study, we also found that aged care services with sophisticated enough IT teams can actually do a mid-layer integration. So if you have an IT team that's able to piggyback onto the data from your clinical data management system, you could actually do it in-house as well.
Yeah, so it's actually easier than it might seem. Do you see any worldwide applications and opportunities within the LDAC project? And I guess I'll follow on from that. If so, what are the how do the approaches differ between different cultures and I guess practices around death and dying and the aged care systems?
That's a really interesting question, very close to my heart as well, because I'm from a culturally diverse background, and I do see there is not one universally accepted understanding or definition of how people die and what death is even. For now, I think LDAC being a national project, what we're building is really relevant to the Australian context, but that doesn't mean that what we've built is not open to being testing and used in the international context. Obviously, the cultural and societal influence on how people die and how people are cared for in the last stages of life would have to be taken into consideration. But again, the prototype is really really flexible. If we have someone from Nepal approaching us saying, "Hey, we would like this," there is no doubt we could be like, "How can we make this work?" So obviously, there's always opportunity.
And this sounds like such a critical area of research, and one with, I guess, tremendous exciting opportunities for innovation. I can imagine there are people out there considering a research career in palliative care, and is following in this trajectory. What advice would you give to someone that might be considering that type of career?
I would firstly go, yay, because I'm very passionate about research and technology and aged care. Well, look, I think I would say that this is an area that really needs a lot of work, and there is so much that could be done. And it is so meaningful in that as a society, we are still at the stage of trying to be comfortable talking about death and dying, where the reality is everyone who's born, it will die. So I think the opportunity to really contribute towards that push and that transition, almost historical transition of, let's talk about death. And, the part of that process is, we have to be comfortable about talking about death, but then the next step really is about planning. We plan about births, we plan about birthdays and weddings, everything. Death is such a major event, and we don't plan about that. So really, I would say for anyone who has any vague remote interest in death and dying, palliative care, end of life, and technology, this area will grow bigger and bigger, and we will need creative and explorative minds to really come and work together with us to, contribute meaningfully, overall to this sector, but also, to the society.
So absolutely, and I loved your slide where you mentioned that life has a 100% mortality rate. I wish we could get certainty like that in other areas. Well, we're actually bang on running out of time and bang on time at the moment. Really wanted to say thank you very much. It's been a wonderful and insightful discussion and presentation, and it's a fantastic piece of research, which I know is going to have tremendous impact on society and our community. So thank you very much, Priyanka, for sharing your time and your knowledge. I'd also like to thank the guests who have joined us today for their participation and their interest in the topic and in Flinders University. I'd like to remind everybody, if you would like to watch this session again or any of our other Meet the Minds sessions, you can view them on the Flinders University Meet the Minds webpage, and you can also get notifications for future events. We've actually got our next event next Thursday, which is on the topic of diversity and inclusion in the workplace and whether it can actually boost the bottom line, which will be another fascinating topic. And that's held with Dr. Ashok Manoram next Thursday, the 22nd of July at 12:30 p.m. So please join us if you're interested. Thank you once again, Priyanka, and thank you for
the opportunity. Thank you.
Thank you.